Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to Voices of Otolaryngology. I'm with a new friend, Dr. Michael Topf. Michael, good to have you this morning.
Yeah, good morning. Thanks for having me. True
Yeah,
privilege.
so we've never met.
No, we have not met.
Good, I'm just making sure. Sometimes we've met and I've forgotten, so I'm super excited to make a new friend. I'll tell you how I came across some of your successes, but do you want to tell us a little bit about yourself? Where are you these days?
Yeah, I'm at Vanderbilt University Medical Center in Nashville, Tennessee. I was raised in Rochester, New York. My father is actually an otolaryngologist, so have always been driven to pursue medicine and otolaryngology, and did my residency training at Thomas Jefferson and then fellowship at Stanford, and I've been at Vanderbilt for the last 6 years.
That's fantastic. Big country music fan?
I like country music. I wouldn't necessarily consider myself a big fan, but I do like country music, and there's plenty of it here in Nashville, Tennessee.
All right. What's your genre of music then?
I kind of like rock. Country rock kind of vibe.
Yeah. Awesome. I'm a big country music fan, so I invite myself down to Nashville all the time. So really enjoy it. So your father, son of an otolaryngologist, that's got to be fun.
Yeah, it's been really, really fun. He is still actively practicing and starting to kind of slow down, but it has been really fun to talk otolaryngology with him over the last, 10 plus years.
Do you think he's going to watch the podcast?
If I send it to him.
Yeah, he might not. My mother doesn't read my bulletin articles, so my feelings aren't hurt. Tell me about your dad's practice. Do you know where he trained and where the practice is?
Yeah, he trained at the Mass Eye and Ear in the 80s, and he has been in private practice in the greater Rochester, New York area for obviously 30 plus years, and has a true general otolaryngology practice. I'd say earlier in his career, perhaps had a little bit of a head and neck lean, but truly does all aspects of otolaryngology. Maybe just not complex ear.
Yeah, wow, that's awesome. What a great career path. What was your earliest otolaryngology memory?
I think my first true memory of otolaryngology was probably early in medical school, or just before medical school, getting to shadow him in the operating room and go to the pathology lab with him. Must have been some sort of head and neck case, and I just kind of seen how as surgeons and as otolaryngologists, we really are responsible for being a team leader in the operating room and kind of orchestrating that, the anesthesia team, the scrub tech, the nurse, and just seeing him kind of work through a day was really, really cool and inspirational.
Yeah, that's great. We're going to circle back to your father's practice, but you're probably wondering why in the world we're doing this podcast, because I'm not talking about your research and science or your practice, but I promise we'll get there. So I saw something in the news about a month ago about you and a group got a quite substantial grant. And for full disclosure, you and I have never met. We haven't even prepped for this, so you don't know where I'm going with this. Cool. But I was really impressed. I was impressed by the words precision head and neck surgery, Michael Topf, Vanderbilt. I said, I got to talk to this guy. So can you tell us about the grant, some of your research, and what motivates you?
Really through a medical student and also just kind of under my background of head and neck cancer and understanding unmet needs, we got super into 3D scanning of surgical specimens ex vivo in real time to create a model of a resected cancer specimen that can be used for downstream communication among the multidisciplinary cancer care team. That we started annotating these models in CAD, computer-aided design software, and realized that, the stuff that is off the shelf isn't really designed for this clinical use. And started working on, with collaborators at Vanderbilt and bioinformatics, started working on our own software to annotate a 3D model of a resected cancer specimen. Could be head and neck, could be breast, could be sarcoma. And recently received some funding through Yosemite to further develop that software. And we're about a year into that right now, and very excited about all the progress that we've made.
And I don't think you mentioned, where did you do your med school?
I did my med school at University of Rochester School of Medicine and Dentistry, and had great otolaryngology mentors there, specifically Sean Newlands, Matt Miller, Lee Mann.
Yeah, terrific individuals. So I'm a bit confused because you're looking at this a little bit differently and modeling. So you're talking about resected cancer.
Correct.
So let's take oropharyngeal cancer. You resect it, then you build a model of it. Explain that to a naive pediatric otolaryngologist. Usually we talk about surgical planning, but you approached it the other way. Talk about that kind of paradigm shift and help me understand the value of that, because it's already out. Why are we building it?
Yeah. If you look at our pathology reports, and head and neck cancer is pretty bad, breast cancer is even worse. They are just, 5-10 pages of written text that describe the specimen, and these gross descriptions. I'm not sure a ton of people read them, but the real inspiration is, why have written 10 pages of written text when you could have a 3D model? And that can show the severity of the patient's disease process, but it also can allow for the annotation to clearly show the sites of margin sectioning and inking, so that if a surgeon has a closer positive margin, they can have a more meaningful conversation with their pathology colleague on exactly where that margin is.
So walk me through an oral cancer, give me the dimensions, and walk me through a use case. Have you used this for patients?
Yes, we've used it for patients. I think it's important to note that, nothing that we are currently using, though we have interest, is FDA approved. And therefore, anything we do is, approved via our institution's local institutional review board on study. But, surgeon performs hemiglossectomy for a T2 oral tongue cancer. A hot topic within head and neck cancer is whether you take the margins off the specimen or off the tumor bed. For purposes of, kind of our solution, it doesn't matter a ton as long as it's clearly denoted. But we are going to quickly, in 8 minutes or so, via a mobile cart that we built, white light 3D scan that surgical specimen, create a permanent visual log of what that resected cancer specimen looks like. The specimen then goes to pathology alongside the pathology assistant, who is the one who's actually processing and grossing the specimen. Our research team observes and creates, to the best of our ability, a digital twin of that resected cancer, and it's processing, inking, sectioning, etc. And that can be used either during surgery in real time via the existing overhead monitors in the room for communication, or it can be used post-operatively when 1 to 2 weeks later, depending on your institution, you're getting that final pathology report back. We can use that model to have a conversation amongst the surgeon and the pathologist. And then, thinking even further ahead, can we use it farther downstream in the cancer care journey? We're actively giving patients models of their resected cancer specimens, and kind of studying whether they like it or not. I'll tell you, thus far, I'd say about 3/4 of patients really, really feel empowered and have a better understanding of their disease process if they have a 3D printed resin model of their resected cancer. What we're really excited about is providing the radiation oncologist with this model, right? So if they need to do a radiation boost for a closer positive margin, it helps them kind of more precisely deliver that radiation dose and boost. Because actually, when you talk to a radiation oncologist, some of the most challenging cases that they have are the resected adjuvant head and neck cancer cases.
Yeah, beautifully described. Thank you. When did you finish your residency?
I finished residency at Thomas Jefferson in 2019. I finished fellowship at Stanford through the American Head and Neck Society in 2020.
Yeah, this is how you and I are a different generation. I was waiting for 1989 or 1995, but you finished in 2019.
That is correct.
Yeah. Yeah. So you and I are a generation apart, 15 years apart. So in our training, we would resect that send that specimen to the pathologist. Pathologist would call up and say margins closed, and we would just take more. And then we would play this game for hours. Go back a second, about 3-4 minutes ago when you were talking, you said there's 2 ways to delineate the margin. You can take it off the specimen or the tumor bed. Just for the non-head and neck surgeons out there, can you just quickly explain that?
Yeah. It's a hot topic within head and neck cancer right now. That being said, when surveyed, we're still fairly 50-50 split in terms of how we take our margins. So you can take the resected cancer, send it to the pathology lab, and have them take either perpendicular or shave margins off that specimen. That's called a specimen-based approach to intraoperative frozen section margins. Or after you take out the resected cancer, you can, send margins from the resection bed or the tumor bed, either, circumferentially or just in areas of concern. And that's called tumor bed-based margins. Super hot topic within head and neck cancer right now. There is some evidence, mainly retrospective, though, one kind of prospective clinical trial to suggest that a specimen-based approach results in improved oncologic outcomes. However, the specimen-based approach admittedly is a bit more time intensive because oftentimes it requires the surgeon to leave the operating room and go to the pathology lab and have an in-person conversation with the pathology team.
Yeah.
And actually, our 3D scanning is a potential solution to that.
And where does Dr. Michael Topf rest in the debate? Are you a specimen guy or tumor-based guy?
I am a specimen guy. I think the data is fairly compelling, though, again, not everyone, their institution is set up for it. So and that's oftentimes when people do tumor bed-based margins, one of the most commonly reasons cited, causes is just, I don't have my pathology team won't do this for me.
Yeah, I'm just a humble pediatric otolaryngologist, but if it was my mouth, I would want tumor-based, because then I think intuitively it makes sense. You're going back and you're not finding any residual tumor. Do you buy that, or is that a fallacy in my thinking? You can say I have a fallacy of thought. Don't worry, my wife says that all the time.
I think it's a little bit of a fallacy. It's oftentimes, my mentor and chair, Evan Rosenthal, loves to say, and he's right, the deep margin is often the problem. And we can send these circumferential mucosal-based margins, but you're not going to take all of that deep margin cavity and send it as a tumor bed-based margin. So I think you could be falsely reassured by just taking some random tissue as a deep margin and hearing that it's clear. And I think, if possible, not every case is possible, if possible, I really like a specimen-based approach to margins. But
wonderful description. I love how
hot topic.
I love how you threw in your chair, Dr. Rosenthal, newly elected into the National Academy of Medicine. Fine, if you want to play that game, I'm just kidding.
Go.
But
yeah,
wonderful point about the deep margin. I wasn't really considering that. Can you expound upon that? That's a really great thought there for our otolaryngologists out there. You both believe it's the deep margin where recurrence and problems come up from. Can you build on that?
Yeah, actually, kind of, when you look at the literature, fairly understudied. So if there are any students or residents or fellows, listening to this, consider looking at your own institution's data. But, you have your mucosal margin, your surface-based margin, that may be your anterior, posterior, lateral, medial, and then you have that whole deep margin. And there's been one major study that's kind of delineated the deep margin, the mucosal margin, and 80+% of positive margins are actually deep margins.
Wow.
But that has not been studied extensively, and I would encourage anyone listening to this to take a look at their institution's data.
What's amazing speaking to you is you and Dr. Rosenthal, maybe your lab or the way you've been trained, is to identify simple questions, but then use sophisticated ways to solve it. I've always thought about the deep and superficial margin, but I didn't know 20 years later, we still have an opportunity to study it. And I love where you've gone here with the 3D reconstruction of an excised cancer. Pull back to your days at Rochester. You and your lab thought about this. Back then, I would have said, wait a minute, you're completely missing the game here. What made you think about it? It's cutting edge and it makes a lot of sense, but a lot of great ideas start just how you did. Back then, people probably thought you were a little bit confused. So, what made you think about that? It's a great idea. Now it's proving out to be the future of precision surgery.
Yeah, I've had really good mentors that have had excellent relationships with their pathology colleagues. So when I was a resident, Dave Cognetti, Joe Curry, Adam Luginbiel all had a really strong working relationship with their pathologist. They'd go to the pathology lab, they'd talk about the specimen together. And then similarly, when I was at Stanford, Dr. Rosenthal when he was there, but also Chris Holzinger, I really think is a thought leader on surgical quality and margins. And they were just all, both those experiences super inspirational, but also like there's an unmet need for documentation, and also just going to the pathology lab as the faculty takes time, right? When I was at Stanford, the operating rooms we were operating were in a completely different building as the pathology lab. So like it was a 8-minute walk there, 10, 15 minutes in the lab going over the specimen. Maybe they're not completely ready for you when you're there. Maybe it's 20, 25 minutes there. And then another 8-minute walk back. That's a lot of time for the faculty member to be out of the OR. I mean, it's critical, results and communication of the main resection specimen, but there's just a lot of time. So I kind of drew on those experiences and look for potential solutions.
Yeah, we use a background for these podcasts, and you might be in your office, you might be in the library, you might be in your car. If you're where something you can reach, do you have a specimen in front of you? Do you have a model in front of you?
Yeah.
Just look around your office. You're in your office, presumably, or unless you keep them in your car. But that'd be awesome.
So this is a 3D printed resin, and I'll give Vanderbilt University Medical Center 3D printing lab some credit here because they support us in this. But this is a resin model of a laryngectomy specimen. So, these are the kind of,
So walk me through that. What am I seeing? It's incredible.
This is a model of a human larynx.
You can pull it back to your body, probably closer to where your tie is. Yeah, awkward for you, but great for us. Yeah.
Good. And, when you're doing a laryngectomy, oftentimes to visualize the mucosal surface, as surgeons will cut posteriorly. And then often, I don't know, I always put a little cotton tip applicator here so you can actually see that, a little Q-tip there to prop it open. But there is, this is actually a prior trach site down here. So I can't remember this case, but the patient had a prior trach. And then up here, there's just an ulcerative kind of false cord and kind of pedal epiglottis, anterior larynx tumor. So that we're providing these models to some patients now, but also what we can do, since you asked, is here's this looks like a right-sided kind of composite, maybe left-sided composite resection here. And here's a tongue, and here's part of a jaw. We can annotate it. So we mark it up in computer-aided design software. And this is how exactly you can see the white lines are the sections, and the ink is the ink, the color is the ink. This is exactly how the specimen was processed. That way, if the pathologist, when they sign it out, says, hey, Mike, your posterior margin is focally positive, that's section C, that actually means something to me. Because I have a model. And I can say, oh, you know what? I'm not that concerned about that because that's maybe superseded by a level 1B neck dissection. Or I can say, that's really, really surprising to me. That's not what I saw clinically. Perhaps this disease process is a little bit more insidious and advanced than I thought it was going to be. Because none of us, obviously, intentionally cut through cancer, but it happens. That's head and neck cancer. It can be, the biology can be challenging.
That is awesome. Awesome. I love it. Thank you for showing us those visuals. I can't wait to come and visit you all and see that. That is incredible. So There's a few things here. One, you have models on an individual patient level. Number two, you're amassing a massive macro level data set through CAD software. I grew up in an engineer's office, so I'm all about CAD. What's the next steps? I can see personalized, but I can see personalized with the capital P, where you roll this out at scale. I don't know what you're allowed to talk about and not, but this is actually fascinating, Dr. Topf.
Yeah. So one thing we're really excited about now, and both Vanderbilt and Dr. Vikas Mehta at Albert Einstein is also doing this approach, is we have an industry collaborator. The company's called Zeos, where we are doing intraoperative PET CT scans. So very similar approach. It's fairly similar approach. It's all ex vivo, right? So we're giving the patient about 1/5 the dose of a whole body PET CT, 1/5 the dose of a whole body PET CT, 30 to 90 minutes prior to resecting the cancer. And then it's a separate cart, but it's a micro CT PET CT scanner. And we are doing a PET CT on the actual specimen. And it works. Like, you can see the FDG activity as you would on a whole body scan on your resected cancer. And we're kind of actively investigating both the radiation safety and feasibility of this, as well as with kind of our 3D scanning approach. We're merging that data set, and thus far have been showing that the PET activity within a millimeter or so is reliably correlating with what the pathologist sees under the microscope. So this is, again, ex vivo, but I'd say this is the project our team is kind of going towards next, is this intraoperative PET CT scanning.
That is insane. I'm literally jumping out of my skin here. That is so exciting. And what's more exciting is you're on the early arc of your career. So I cannot wait to see what comes from this. So let's say back, so I understand it. So someone comes in for a head and neck cancer, and 30 to 90 minutes before the surgery, you inject the isotype.
The radiotracer. Actually, it's 30 to 90 minutes before you resect it. So they're in the operating room.
Okay.
And that's the one thing I think is really attractive to patients with this, participating in this type of clinical research, is that it does not require, at least at our institution, any additional visits, right? You know, that's a big deterrent to clinical trial participation, is patients having to come back for all these visits. We obviously enroll the patient ahead of time at their preoperative clinic visit, but they just come for surgery. It's a fairly easy sell because a lot of the patients have already gotten a PET scan. So when you say it's 1/5 of the dose of a full body PET scan that you already tolerated, great. And then it's all done while they're under anesthesia. So it's really exciting for patients.
30 to 90 minutes before the resection, you inject a radioactive tracer, you take out the cancer, then you bring in a mini CT into the OR.
It's a cart.
Cart.
Yep, it's a mobile cart that you wheel in, and it's shielded, so there's no radiation that is emitted.
You put the specimen in there.
Yep.
And then the output within a millimeter tells you.
We're actively investigating that, but thus far the resolution has been really good, about a millimeter, within a millimeter or so of the final microscopic path. But it could be potentially, used to someday tell you margin status real time.
Exactly. Exactly. And is there a math equation? So if you inject X amount, you in that CT scanner, you're going to get 0.75x or something like that.
PET is all relative. So yeah, there's an SUV max and an SUV min, and you can window it to what you see. So there, you can window the scale and the color into what you want to see. So it is all relative, but we have some kind of normative values that we've been using based on the breast literature, and that seems to be working pretty well thus far.
Have you looked at the patient on the table? Is there any portable CT or a wand or something that you can also put in that area to see if there's residual radioactive uptake, which would indicate tumor left?
That's a very, very thought-provoking idea. We don't necessarily have a way to do that currently, but that is potentially an area of interest. And I will say that Eben Rosenthal's approach, which is slightly different, the patient gets a fluorescent tag agent, 1 to 5 days prior to surgery. That definitely does work to some degree. You resect the cancer, and if you still see activity in the wound bed, that's potentially very concerning that there's active malignancy still there. So Eben's approach works really, really well with that. The FDG is all an ex vivo scanner, so I don't necessarily have like a camera that I can shine in the tumor bed after the wound bed after the cancer's been resected. But Dr. Rosenthal's approach does work well for that.
And you wouldn't be doing these purely for research, for grant funding, for mental exercises. You must see better outcomes. And it's hard to do it at macro level, obviously, but you must be seeing individual examples like, wow, this is really making a difference. Can you share one of those?
Yes. So, yeah, and I want to, definitely emphasize that everything is done, via an IRB approved clinical trial. And I don't think we're quite there yet on, on a more macro or population level improved oncologic outcomes. And, I think our team does a good job of just emphasizing that to patients, that this is something we're investigating. It may help you, but we don't have definitive data to show that it improves oncologic outcomes. Though many patients, fortunately, are really interested in participating in clinical research and contributing to science. And, I'd like, if there are any patients, listening to this, I'd like to that have participated in clinical research, I'd like to thank them, because really they are the drivers. We have really exciting investigators in our field that are pushing it forward, but it's the patients that are contributing their data and helping us help the future generation of patients. I'm trying to think. Let's think of a particular example for you. The intraoperative PET we just have started, so we're 5 cases in on that, and I can tell you that has really thus far reliably shown malignancy. One case that comes to mind was a case of a oral tongue cancer in a female white patient, non-smoker, that had just a lot of leukoplakia. It was a cancer in a field of leukoplakia, and I had resected the cancer, kind of incorporating that leukoplakia as a margin, but not necessarily going as wide around that leukoplakia had I known it was invasive carcinoma. We put the specimen in the intraoperative PET CT scanner, and all of that kind of leukoplakia that was posterior to the nodule that was the biopsy-proven cancer actually lit up very, very hot on the PET CT scanner. And I said, wow, that's pretty concerning. We sent then our kind of gold standard margins, and sure enough, that posterior PET activity was in fact invasive carcinoma. I was close on that margin, ultimately resected some more, but that was an eye-opening case for me to suggest that this approach may someday and during my career be incorporated as a standard of care.
That's awesome. Let's maybe wrap up with a couple of questions where I started off by meeting you. And one of the best parts of my job is making new friends, and hopefully I've made a friend today. Your grant. Can you talk a little bit about that grant? You're quite humble about it. It's no joke to get a $2.5 million research grant at an academic institution. Can you talk a little bit about that, your collaborators?
Yes. So, that particular grant is a grant through ARPA-H, and that is with Jonathan Liu, who is a really, really incredible engineer now at Stanford, previously at University of Washington. And his team does optical lightsheet microscopy. So another different approach to, and I swear I love my pathology colleagues. I'm not trying to get rid of them, but another approach to potentially give a surgeon real-time pathologic results without having to send frozen sections. That also is an ex vivo approach. So it's a tabletop, or we put ours on a cart. It's a cart-based imaging platform that does light sheet microscopy to look at the surface of a resected cancer to try to determine whether there is any active, any malignancy at the surface, at the margin. We're fairly early in that grant, and actively, Jonathan's team at Stanford is actively developing the device. Right now, my role has been really implementing some of it into the operating room and generating preliminary data. But we look forward to future years of that award.
Yeah, great multi-institutional collaboration. I've noticed everything that Dr. Topf does is on a cart. So for Halloween, were you a doctor with a cart?
No,
Putting a cart around. You love your carts.
I have a 3-year-old and I have a 1-year-old, both daughters. And the older one was Elsa. The 1-year-old was Anna. My wife coordinated all this. She got to be Olaf, but I was Sven. I was like the reindeer.
And you probably 3D printed your costume.
Yeah, there you go. No, my wife, with a little bit of my help, did make her Olaf hat. So, but no, my costume was purchased.
Well, let's wrap up with some guidance or wisdom for surgeon scientists early on their career. I know you're shocked. You're 6 years out. You're probably on your way to associate professor. You've made a lot of contributions early on in your career, and you're probably not used to giving advice yet, looking backwards. But what advice do you give to those med students, those residents, about research? It's amazing what you're doing, and I'm being sincere. You're approaching it from a different lens that we hadn't really thought about, but that's what the future is. If we keep going down the same paths, we're going to encounter the same things. So kudos to you for thinking differently. What advice do you give to those residents and med students that listen to these podcasts?
So you're not, as a resident or medical student, you're not going to necessarily have the clinical expertise. So I think go to your mentor and look for a clinical unmet need that interests you. Ultimately, if you're doing research, it really should be to improve ultimate, future patient care. And you need to start with an unmet need. So start with a clinical unmet need. You're trying to obtain funding for this. I think, one thing that my mentor, Evan Rosenthal, has always taught me is it's all about shots on goal, right? The funding landscape is increasingly competitive, and you're dealing with a community and pool of really successful people that are, talented grant writers, and you just cannot be afraid of failure. So, and I'd love to touch base on the AAO core funding mechanism if we have any time. But do not expect to get a grant the first time you submit it, but take the reviewer's feedback, which, they are trying to make your grant better and make your proposal stronger, incorporate it and resubmit. Don't be afraid of failure. Apply broadly and apply often. And, if you have an unmet need and you can tell a story, you can obtain funding.
Yeah, excellent. I've heard that over and over. But again, you just have this wonderfully articulate way of driving home a point. So you saw the World Series. You're hitting 350. You're hitting 400. You might as well be an all-star baseball player. But I just thought about that. If funding's at 16% or 10%, so if you're batting 100, you could be a research superstar. I mean, that's kind of what you're getting at. And by all means, talk about core. I love it when people promote our academy. Please.
I've benefited and from the core. I got a core grant when I was a resident. Adam Luginbill, my mentor, and Joe Curry really encouraged us to apply for core grants as residents, and that was my first grant writing experience. And subsequently, I have participated over the last 5 or 6 years with the core grant review for the head and neck subcommittee. And that has been also a really rewarding process to both give back. I think also selfishly, you get to see a lot of different grant writing styles. And as someone who's writing grants, you can say, like, oh, wow, that's like a really cool way to kind of structure a grant. and learn from other really talented grant writers. But it's also exciting for me because I get to see all the amazing kind of science and ideas that are coming out across the country, and how bright the future of otolaryngology is. If I could give any advice to people that are applying for core grants, it'd be that the funding mechanisms are, receiving a lot of submissions and they are competitive. So, particularly at the resident level, I could see a resident, working really hard on a submission, not having it funded, and then never resubmitting. No, please resubmit. Oftentimes, the proposals that are getting funded are resubmissions, and I would encourage you to take the committee's feedback and the summary statement and try to make your grant better and apply the next year, because there's a good chance you'd get it.
Thank you for that. And our team annotates these webinars. We'll put a contact there to reach out to the Academy through core grants. And thank you for your service on the core grant program. We've really increased core grants in the last year, and we continue to make that massive commitment, especially during this time of competitive restricted funding. Let's end up.
Jeff,
go ahead.
I'll just one more plug for that. Jeff Liu, who actually is chair of the head and neck subcommittee, has a really nice, it's now probably maybe 10 years old, a really nice paper in the White Journal on writing core grants. And I think if anyone's thinking about writing a core grant, look out for that paper from Jeff Liu, because it really does provide a nice kind of roadmap for writing a good grant.
Well, thank you. We'll look for that and try to append it to this podcast as well. I appreciate that. Let's end up a little bit where we started. My late father was an engineer. A couple of years ago, he said, "Yeah, you've done a great job in otolaryngology, but if you're really smart, you would have been an engineer." So tell us the truth. Did your father say your pedigree's awesome, Stanford, Vanderbilt, you're a grant-funded researcher, but the real chops are in private practice? He said, "Come back to private practice." What does your dad think?
My dad has had an awesome career as a private practice otolaryngologist. I don't think I could do it. I just love being in the Vanderbilt ecosystem. And as you said, hanging out with people that are a lot smarter than me. I get to go and walk over to the undergraduate campus, which is just a couple minutes away, and interact with undergraduate students, master's students, PhD students, and professors at Vanderbilt, and bring, problems to them and work through them in an iterative process. So for me, being in an academic center is really exciting and makes my every single day different, along with the patient care and residents and fellows and trainees. But, obviously I have the utmost respect for private practice otolaryngologists who are serving our community and our board for holding everyone to a super high standard.
Yeah, and I'd say if we asked your father, the senior Dr. Topf would say every day is awesome and exciting and different for him, right? So it's the lens that we have. I'll tell you, I'll be the first one to ask you this. When your dad pushes the cart into his OR and 3D prints a specimen, send me a picture of that, because I'll bet you'll be in a couple years. Congratulations, Dr. Topf. Any final words? Thank you for joining us. This was incredibly inspirational and exciting to look at what the future of precision head and neck cancer looks like. Any final thoughts or words?
Yeah, I will just go back to the trainees. I'd say, the American Academy of Otolaryngology has a lot of exciting internal funding mechanisms. If you're interested in research through core at different levels, at resident research level, I was a recipient of American Head and Neck Society, American Academy of Oto Career Development Award, Young Investigator Award, and benefited from that immensely. And then there are even larger awards. So the Academy really does a nice job of supporting research, and I would encourage everyone to participate in that.
Well, great. Thank you very much for your time during your busy schedule, and congrats on what you've achieved. Thank you.
Thanks, Dr. Shah.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.